Hello everyone, I am Dr. Saatwika from Department of Conservative Dentistry and Endodontics, Sri Balaji Dental College and Hospital. In this session, we are going to deal about minimally invasive dentistry, that is reminalization. The philosophy of minimal intervention dentistry is an attempt to combine all the present knowledge of prevention, remineralization, ion exchange, healing, and adhesion with the object of reducing caries damage in the simplest and least invasive manner possible. Teeth are highly mineralized tissues of the body containing biological apatite as the mineral. Biological apatite is a calcium phosphate salt where some of the phosphates are replaced by hydroxyl. The present concept identifies caries as a dynamic process which can be conceptualized as an imbalance between mineral loss called remineralization and mineral gain called remineralization. When the salivary pH drops to 5.5, dissolution of hydroxyapatite occurs. When it goes below 4.5, the dissolution of fluorapatite also occurs. When the pH increases above 6, there is a production of hydroxyapatite and fluorapatite from calcium and phosphate minerals from saliva. The protective factors for remineralization are salivary components and flow, such as fluoride, calcium, phosphate, antibacterial agents. Pathological factors include karyogenic bacteria, fermentable carbohydrates, and salivary dysfunction. The battle to keep strong and healthy teeth is dependent upon the balance between demineralization and remineralization. The evaluation techniques are microradiography, iodine absorptiometry, various microhardness tests, polarized light, and laser fluorescence. Laser fluorescence is a method introduced for early diagnosis of dental caries. It is useful for the early detection of hidden caries in non-cavitated teeth through a non-invasive method. It emits infrared light that can be observed by organic and inorganic tooth materials, and the process of remitted fluorescence shows various scales between 0 and 99. Two theories exist. First, when the red light meets a change in tooth tissue such as porosity due to demineralization or hypomineralization, it stimulates fluorescent light of a different wavelength. Second, some bacterial metabolites such as porphyrins result in red fluorescence. Early detection using diagnodents shows 90% accuracy. Remineralization process is a natural repair mechanism to restore the mineral gains in ionic forms to hydroxyapatite crystal lattice. The ideal requirements of remineralizing agents include it should deliver calcium and phosphate into the subsurface, it should not deliver any excess of calcium, it should not favor calculus formation, should work at an acidic pH so as to stop demineralization during a caries attack. It should work in xerostomic patients also, as saliva cannot effectively stop the caries process. It should be able to boost the remineralizing properties of saliva. In indications, an urgent to preventive therapy for reducing caries in high-risk patients, these remineralizing agents are used. It is used in dental erosions with gastric reflux or other disorders. It is used when there is decalcification in orthodontic procedures. To repair enamel in cases involving white spot lesion. For fluorosis before and after teeth whitening and to desensitize sensitive teeth, these remineralizing agents are used. The reduced pH of plaque surrounding orthodontic bands causes hindrance in the remineralization process of enamel, thus decalcification takes place. This is called white spot lesion. The subsurface enamel porosity from caries demineralization that presents as milky white opacity when located on smooth surface. It has intact surface layer overlying subsurface demineralization. It is greatest on the cervical and middle thirds of the vestibular surfaces of those teeth. It can be remineralized. The diagnosis of white spot lesion. It is given by ICDAS. It is an international caries detection and assessment system. It has given 5 codes for detection of white spot lesion. Code 0, which is sound tooth surface. Code 1, first visual change in enamel when tooth surface is dry. Code 2 is determined when distinct enamel change in enamel when viewed wet. Code 3, localized enamel breakdown due to caries with no visible dentin. Code 4 is underlying dark shadow from dentin with or without localized enamel breakdown. Remineralizing agents are classified into fluorides and non-fluorides. Next, coming to mechanism of action of fluoride. Fluoride ions replace hydroxyl ions in hydroxyapatite to form fluorapatite in tooth enamel, which is more stable and less soluble crystal. Under karyogenic condition, carbohydrates are converted to acids by bacteria in the plaque biofilm. When the pH drops below 5.5, the biofilm fluid becomes undersaturated with phosphate ions and the enamel dissolves to restore the balance. When fluoride is present, this fluorapatite is incorporated into the demineralized enamel and subsequent demineralization is inhibited. Topical fluorides is divided into professional and self-applied. Under professional, we are going to see about neutral sodium fluoride, stannous fluoride, APF solution or gels, and varnish. Under self-applied, there are dentifrices, mouthwashes, and fluoride gels. Coming to personally used fluorides, the first one is dentifrices and mouth rinses. Dentifrices contains 0.1% of fluoride and uptake of this fluoride in etched enamel or in incipient lesions enhances remineralization. Fluoride mouth rinses are advised for school children over 5 years of age, persons with high caries susceptibility, and patients with orthodontic and prosthetic appliances. Fluoride solutions. The topical solution of fluoride used are 2% sodium fluoride, 8% stannous fluoride, and 1.23% of acylated phosphate fluoride solution. Gels adhere to the teeth and eliminate continuous wetting of enamel, and it is possible to treat 2 to 4 quadrants simultaneously. It is applied by brushing or in trays. Brushing is done for 1 minute. Professionally applied, with 2 grams or 40% of the tray is filled and it is used twice a year. Fluoride varnish increases the time of contact between the enamel surface and topical fluoride agent. It favors the deposition of fluorapatite and hydroxyapatite. Total of 0.3 to 0.5 ml of varnish is required to cover the full dentition. Iontophoresis is generally used to maximize the therapeutic action of drugs and medicine. This technique can be used to improve the remineralizing effect of topical fluoride applications in dentistry. A low voltage electric current is used to impregnate the tooth with fluoride ions, 2 to 6 times more dentin when then treated with topical sodium fluoride. Next, coming to non-fluoride remineralizing agents. First is amorphous calcium phosphate. The current sources of calcium and phosphorus are two salts, calcium sulfate and dipotassium phosphate. When the two salts are mixed, they rapidly form ACP that can precipitate over the tooth surface. Next is casein phosphopeptides amorphous calcium phosphate. CPP stabilizes and localizes ACP at the tooth surface, thereby buffering plaque pH, depressing enamel demineralization and enhancing remineralization. This efficient incorporation of CPP-ACP nanocomplex into the plaque, where the CPP carrying the stabilized nanoclusters of hydrated ACP bind into the bacterial cell and intracellular matrix micromolecules, localizes the bioavailable calcium and phosphate ions to the tooth surface. The products available: the chewing sugarless gums containing Recaldin for 15 minutes. It longer allows optimal dispersion of Recaldin complexes through the oral cavity. Casein phosphate amorphous calcium fluoride phosphate. Here, the fluoride is incorporated to the CPP-ACP complex. The predominant mineral which is formed during remineralization of enamel subsurface lesion with the use of CPP-ACP is hydroxyapatite. The major mineral formed there during remineralization with the use of CPP-ACP along with fluoride causes deposition of fluorapatite, which is highly resistant to acid attack when compared to hydroxyapatite. Next, coming to beta tricalcium phosphate. It is a new hybrid material created with a milling technique that fuses beta tricalcium phosphate and sodium lauryl sulfate of numeric acid. When TCP comes into contact with the tooth surface and is moistened by saliva, the protective barrier breaks down, making calcium phosphate and fluoride ions available to the tooth. TCP has also been considered as one possible means for enhancing the level of calcium in plaque and saliva. Next, coming to bioactive bioglass. The bioactive glass, when in contact with saliva or water, first releases sodium ions. This increase in ionic concentration, combined with an increase in pH, causes the ions to precipitate onto the tooth surface, and form calcium hydroxycarbonate appetite to remineralize the defect and occlude dentinal tubules. Bioactive glass is made of synthetic mineral containing sodium, calcium, phosphorus, and silica. The product is Novamin, which transfers into HCA for up to 2 weeks. Next, coming to enamelon. It is an unstabilized calcium and phosphate salts with sodium fluoride. Delivers fluoride along with soluble calcium and phosphate, the building blocks of enamel. Enamel in toothpaste is beneficial in reduction of white spot lesion and repair and remineralization of tooth enamel compromised by acidic beverages. Pro enamel is targeted to help with the problem of dental erosion. It contains 5% potassium nitrate to help relieve tooth sensitivity. It has a neutral pH and a low abrasivity. Dicalcium phosphate dihydrate, it is just incorporation of dicalcium phosphate dihydrate that identifies, upsurges the level of free calcium ions in plaque fluid and they remain elevated for up to 12 hours after brushing in comparison to conventional silica dentifrices. The possible mechanism of action of trimetaphosphate ion is believed to influence the absorption of the agent to the enamel surface, creating a barrier coating that is competent in inhibiting or retarding reactions of the crystal surface with its fluid environment, thereby reducing the demineralization during acidic challenge. The efficacy of TMP can be associated with the fact that TMP benefits the diffusion of calcium ions to the inner of enamel or reduce their loss to the solution. Next comes the calcium carbonate carrier, that is Sensitat. This is also called as Cavistat. It is an arginine combination with calcium and bicarbonate or carbonate. The mechanism of action is when arginine combined complex binds to tooth surface and allows the calcium carbonate to slowly dissolve and release calcium. The commercially available products are Proclude and Dentlude. Ion exchange resins provides a controlled release system which supplies calcium, fluoride, phosphate, and zinc ions to promote remineralization. Torado et al. Evaluated a dentifrice containing mixture of ion exchange resins and concluded that inclusion of calcium phosphate ion exchange resins helps promote remineralization. Next comes the biofilm modifiers. The following therapies were designed to enhance the remineralizing effects of fluoride by affecting the amount, composition, and metabolic activity of dental biofilm around caries lesions. First is arginine. The amino acid arginine can affect the pH and ecology of oral biofilms. It is introduced to toothpaste with insoluble calcium and fluoride to enhance caries lesion prevention through greater remineralization. This potential effect on biofilm pH could supplement mechanical plaque control, helping to maintain biofilm homeostasis with the host. Triclosan is an antibacterial agent. It affects biofilm acid production that leads to higher saturation and therefore higher mineralization. Adding triclosan to the dentifrice formulation showed reduction of coronal and root caries incidence in children and adults as showed by Relay and Lamonge in 2013. An in situ study conducted in 2004 suggested that it might also have an effect in remineralization by Silva et al. In 2004. Chewing xylitol containing chewing gums helps indirectly in preventing remineralization by its effect on streptococcus mutans in the oral environment. Study done by Sintes and Augusto et al. In 2002 showed that a dentifrice containing 0.836% of sodium monofluorophosphate in a dicalcium dihydrate base plus 10% xylitol was effective in caries prevention, better than a similar dentifrice without xylitol. Minerals from saliva or minerals supplied by other therapies need nucleation sites for precipitation and remineralization. When low viscosity peptide solutions can be introduced into the enamel lesions to spontaneously create scaffolds capable of hydroxyapatite nucleation that promotes remineralization by Kirkham et al. In 2007. Ozone attacked by many biomolecules and changed the surface ecology of caries lesion. The reversal of primary root caries lesion causes demineralization plus reduction in asdogenic and asduric microorganisms. There occurs caries reversal, that is, shifting the microbial flora in caries lesion to one containing normal oral commensals. Pyruvic acid can be converted to acetate and carbon dioxide by ozone. Heel ozone remineralization solution contains xylitol, fluoride, calcium, phosphate, and zinc. Grapeseed extract has a high proanthocyanidin content. Proanthocyanidin treated collagen matrices are non-toxic and inhibit enzymatic activity of glycosyl transferase, FATPs, and amylase. Hence, inhibition of glucosyl transferase by PA in turn inhibits KDs. GSC, that is grapeseed extract, acts as a potential adjunct of or alternative to fluoride in treatment of fruit caries during minimally invasive therapy, although further research is warranted. Next, coming to nanohydroxyapatite, a concentration of 10% nanohydroxyapatite is considered to be optimal for remineralization of early enamel caries. Also, nanohydroxyapatite has the potential to remineralize erosive enamel lesion caused by exposure to soft beer and other aerated beverages. Toothpaste containing nanohydroxyapatite reveal higher remineralizing effects compared to amine fluoride toothpaste with bovine dentin. Next, coming to lasers. Powell GL introduced lasers inhibits caries, but their efficacy increases when they are supplemented with remodelizing solutions. The argon laser seems to be the most widely used laser in caries inhibition. In the study by Pusti et al., carbon dioxide laser before APF application or the simultaneous treatment of teeth with carbon dioxide laser and acylated phosphate fluoride significantly increased remineralization of white spot lesion, and they were more effective than acylated phosphate fluoride alone or the control group. ER-YAG laser irradiation at lower energy densities have shown significant inhibition of enamel demineralization. This reduction has been attributed to the surface temperature achieved during enamel laser irradiation. Keshani et al. Found that ER-YAG laser irradiation at lower energies can decrease enamel solubility without severe alteration of the tooth structure, even under cooling effect of water flow. Bevilacqua et al. Concluded that ER-YAG laser irradiation combined with topical application of fluoride showed a beneficial effect on enamel acid resistance. They also reported that a higher energy density resulted in a greater resistance to mineral loss. Conclusion. Evidence suggests that initial non-cavitated lesions can be remineralized using appropriate technologies, both fluoride and non-fluoride based. Saliva plays an important role in the remineralization also. It is important that demineralization can be controlled with the reduction of biofilm and its modification. Thank you.